Good morning and welcome to Department of Pediatrics Grand Rounds. I'm Mark Roback from the Division of Emergency Medicine and Child Abuse, and it's my pleasure to introduce our speaker today, Dr. Kari Schneider. Dr. Schneider is a Wisconsin native and did her undergraduate studies at the University of Wisconsin at Madison, where she studied medical microbiology and immunology. As a former microbiology major myself, I can tell you it's a direct route to emergency medicine through microbiology. Kari completed residency in pediatrics at St. Louis Children's Hospital, followed by a fellowship in pediatric emergency medicine at Cincinnati Children's Hospital and Medical Center. During her fellowship, she developed an interest in adolescent sexual health, and she did perform 2 projects while a fellow, which she got published as she came here to work with us. In 2014, Dr. Schneider joined our division and here at the U of M Masonic Children's Hospital. In her short time in our ED, Dr. Schneider has become a favorite of our nurses and residents due to her clinical skills and her overwhelmingly positive attitude. Anybody who's worked with Kari knows what that means. She's also a preceptor in our EPAC program for medical students on the fast track for pediatrics. Since joining our group, Dr. Schneider has continued to pursue her interests in adolescents and sexually transmitted infections, and today she'll present Adolescents at Risk of Asymptomatic STI in the ED. Please welcome Dr. Schneider.
Thank you, Mark. That was very, very sweet. Thanks for having me this morning. As he said, I'm Kari. I work in the ED, just joined a couple years ago, and my area of interest is a really popular one, STIs in teenagers. And actually, given the topic of today's talk, I really thought it would be like standing room only here today, so I'm a little bit surprised, but I think it's the weather, so that's all right. But thank you all for joining me. I really appreciate you being here, and hopefully you can all take something away from the talk today. Let's get started. First, I have to tell you that I have no financial relationships to disclose. I won't be discussing any off-label use of anything at all. I also have no parting gifts for anybody, so fortunately for you. Today, I'd like to convince you of the problem that STIs pose to our adolescents and discuss the latest recommendations when it comes to diagnosis and to treatment. I'd also like to tell you about some of the work that's come out of the pediatric emergency department in particular, and including some of my work. And hopefully by the end, you'll want to go forth and cure the world of gonorrhea and chlamydia. So a little bit of an overview. We'll start with a problem, we'll move into some of the recommendations, and a little sprinkle of teens' rights just to remind everybody. And then we'll talk about the pediatric ED and what's going on there now. While my area of interest is obviously the emergency department, I hope that some, if not most, of what we talk about today can be applied to wherever you practice. Maybe not the NICU, but elsewhere. So the problem. Nationally, 15 to 24-year-olds account for half of all new STI infections, a huge disparity. For example, the prevalence of chlamydia in this group is 3% compared to 0.5% for all other age groups. And why is this? There are some unique factors to our adolescent patients. First of all, insufficient screening. Many women don't receive the chlamydia screening that's recommended, and according to a review of all of the U.S. Preventative Service Task Force recommendations, screening females under 25 years of age for chlamydia is included in the list of some of the most beneficial and cost-effective prevention services that can be offered in medical practice today, and that includes like aspirin use, colonoscopies, childhood immunization. So it's up there on the list of really important things, but it's also one of the most underutilized. Then we have confidentiality concerns. Of course, many teens are reluctant to disclose risky behaviors to their physicians. You may also recall, or maybe not, from medical school that biologically young women are more susceptible to STIs because of increased cervical ectopy, which is you have columnar cells inside that are usually inside the cervical canal, but during adolescence are outside, and they're very sensitive to invasion by sexually transmitted organisms. So biologically, they're also at risk. Then there's lack of health care. They often lack money, insurance, transportation to get to the prevention services that they need. And many young people have multiple sex partners, which of course increases their STI risk. This nationwide disparity holds true here in Minnesota as well, and it's obvious when you look at the graphs that I have. This is the 2015 Minnesota population. 15 to 24-year-olds were only 13% of the population in 2015, but as you can see, this age group made up a disproportionately large percent of the STIs in the state, with 64% of chlamydia infections and 47%, nearly half of gonorrhea infections.
A type of
the rate of chlamydia in Minnesota reached an all-time high in 2015, hooray. So 400 per 100,000, and the rate was an increase of 7% from the preceding year. And the rate of gonorrhea in Minnesota remained steady at 77 per 100,000. So holding steady.
This is called a graph.
And then what do we have here at Masonic?
Two things.
So I asked our lab for the number of gonorrhea and chlamydia tests that were sent in the past year in 2016. And these numbers, sadly, are not just from our emergency department. This is all of Masonic inpatient and outpatient clinics. We only sent this many tests in the past year, which I was surprised about. One thing, though, that it was impressive is that the chlamydia rate is on track with that national prevalence that I mentioned before of 3% in the 15 to 19-year-old age range. So it's actually an impressive rate given that overall we see a pretty specialized subset of patients here at Masonic, and we're still holding steady with what is being seen nationally for teenagers. So let's talk a little bit about recommendations for us when it comes to STI screening. The next couple slides, very small print, but I'll tell you what you need to know from them. I just wanted to show you where these recommendations are coming from. The United States Preventative Services Task Force recommends screening for gonorrhea and chlamydia in sexually active women aged 24 years and younger. And the important point that I want to make is that it's not patients that are having high-risk behaviors. It is just if you're sexually active and you're less than 24, you need to be screened. The CDC has the same recommendations for all sexually active women under 25, no matter if you're high risk or not. For men, there's really insufficient evidence to give strict recommendations, and so they suggest that we screen in high prevalence clinical settings, kind of like in an urban pediatric emergency department would fall under that category, in my opinion, or populations with high burden of infection like men who have sex with men. And then the for gonorrhea. And there are really no studies that on screening intervals, and so the sources suggest that we just have that a reasonable approach would be to screen patients whose sexual history reviews new partners or persistent risk factors since the last time that they were tested. I kind of use like a 6 to 12 month sort of range, and I'll ask patients if they've been tested within that time frame, and if they haven't, then I'll go ahead and screen. But there's no set screening recommendations for intervals. And I guess the kind of the at the end of my sentence about the need for screening is this statement from the National Commission on Prevention Priorities, is that if 90% of eligible young females were screened for chlamydia, 30,000 cases of PID would be prevented each year. So not an insignificant number. Our options for screening are cultures and nucleic acid amplification tests. The nucleic acid amplification tests are much more sensitive than culture, and non-invasively obtained samples like self-swabs of the vagina and rectum are just as accurate as those obtained by physicians from the endocervix, and a lot more pleasant for everybody involved. The evidence suggests that self-taken vaginal swabs have a better sensitivity than the first catch urine, which just makes sense because they probably collect more material when they do it that way. And I've double and triple checked with our microlab here and confirmed that we can send these nucleic acid amplification tests on anything that we'd like. They have 3 different collection kits, urine, a vaginal self-collection kit, and then one for endocervical, urethral, throat, and rectum. They can even do from the eyes. It's not FDA approved for that use yet, but they can do it and they'll send it out with a waiver attached to it. So you can really get it on anything that you want. Culture is not completely useless to us anymore. In cases of suspected or documented treatment failure, we need to be sending a culture so we can look for antimicrobial susceptibility. Testing, because we can't get that with the nucleic acid amplification techniques, and that'll be really important for gonorrhea, as I'll talk about in just a minute. You can always look up the treatment recommendations and doses if you need to. It's mostly important to recognize the importance of the 2-drug regimen for gonorrhea, and we'll discuss why in just a moment. But patients who've been treated with gonorrhea also need to be retested in 3 months after treatment, regardless of whether they believe their sex partners have been treated or not. And if that's not possible, then the recommendation is just, whenever you get to see them next, try to get that retesting done. Almost as important as the initial treatment itself is counseling the patients on next steps, abstaining from sex for a week, and until all their symptoms have been resolved, and making sure that they tell all of their partners and that they get tested and treated as well. If they're positive for one STI, they should probably be being tested for all of them. And we treat gonorrhea the way we do and care about test of cure because of the sneaky ability of Neisseria gonorrhea to develop resistance to antimicrobials. In 1986, the gonococcal isolate surveillance project was started. It's a national sentinel surveillance system. It was established to monitor trends in antimicrobial susceptibilities of urethral gonococcal strains or gonorrheal strains in the United States. And in 2007, we had fluoroquinolone resistance emerge in the United States and prompted the CDC to stop recommending those be used for treatment of gonorrhea, which really left the cephalosporins for us. And then over the past several years, resistance to cefixime has been developing to the point that the CDC no longer recommends it. They were concerned that continued use of this might also hasten the development of resistance to ceftriaxone, which is our last remaining antimicrobial that's known to be highly effective in single-dose therapy for gonorrhea. So in 2010, the guidelines changed to recommend dual therapy for gonorrhea with cephalosporin plus azithro. And the take-home point here is that maintaining effectiveness of ceftriaxone for as long as possible is critical. And I know we all care about antibiotic stewardship and it being really important. Sometimes this can be a little controversial in the emergency department because we tend to be kind of a treat and street mentality. Like if we think you might have an STI, it's very easy to just give you the shot, give you your gram of azithro and send you on your way. But I would kind of urge people to think about changing their mindset, and if we could potentially wait and see if it's not a rip-roaring discharge coming out, if maybe they've got a yeast infection and they are sexually active, send the treatment, get a good phone number, and see if we can follow it up.
15 minutes.
But imperative to that plan is being able to contact the patients with their results. My mentor in Cincinnati, Dr. Reed, and a group at Cincinnati Children's worked on increasing the proportion of patients that they could reach by phone with their test results, and they increased it from 45% to 65% and decreased their loss to follow-up rate. And that was almost entirely done by focusing just on making sure they had a good phone number to reach them at and document that confidential phone number in the electronic medical record. They also handed out to the patients these little patient activation cards and utilized a cell phone that was given to a nurse practitioner, and the cell phone was dedicated just to contacting the patients and being available to be contacted regarding their results. They also learned that teenagers tend to buy cell phone plans with so many minutes on them and will use up their minutes quickly and then not have minutes anymore, and so they will frequently not check their voicemails because it uses minutes. And so they started moving towards texting the patients and had a much increased response to getting a hold of them by text message. It's also very important for adolescents to be aware of their test results. And I would stress this even in the case when they're empirically treated. Sometimes we will treat them, their test result comes back positive, we'll see, oh, they've already been treated, no big deal. But optimal STI control requires more than just testing and treatment to disrupt transmission. The CDC actually urges us to counsel the patients on partner treatment, safer sex practices. Dr. Reed's group at Cincinnati also followed up by phone a convenient sample of adolescent women who were all empirically treated in the ED or an STI or a teen clinic. And they found that if they believed they had an STI, they were more likely to abstain from sexual activity and notify their partners. And then women who were treated with the antibiotics but didn't really believe that they had it and weren't notified that they had it didn't change their behavior. So knowledge is power for our patients, even if they've already been treated. It's really important that they know that they were positive. To remind ourselves in our ED, of the importance of a confidential contact phone number, we utilize an STI dot phrase. It's especially important in our practice because most often the person who sees the result is not the person who sent the testing, and so we don't know exactly what the plan was. And so being able to look back in the provider note and see this dot phrase, it tells us what happened, how we're supposed to contact the patient, reminds us to not only document the confidential number, but whether or not it's okay to leave a message for the phone on the phone for the patient or discuss results with others, because sometimes their parents are aware of what's going on and it's okay to talk with them. It's been very helpful for us. Getting a positive patient's partner notified and treated is the next step in the battle, and an important one that I think we can play a role in. I've always personally offered the patient my assistance in that. I've actually never been taken up on that offer, but I'm willing. There are a variety of anonymous ways that patients can let someone know that they've been exposed. The cartoon e-card at the beginning of my talk, you can send anonymously. The knock knock, who's there is chlamydia. You can send that one anonymously. I found this other one, inspot.org, was recommended by some various websites. You can go through, pick out a card that you like. I thought this one was rather poetic. You can put your own little message on there. And so mine, I just put sorry. And you can send that out and it won't say who it's from. I sent it to myself. I thought about sending it to a couple residents just to see what would happen, but I didn't. So if you get one, it wasn't from me. It would be a whole thing. There's a lot of options with really fun names like don'tspreadit.com or stdcheck.com, which will actually allow you to anonymously text message someone, and then letthemknow.org. There's a lot of ways you can just Google how to anonymously tell someone you have an STI, and the world is your oyster. The best approach for treating a partner of a patient diagnosed with an STI is really for them to undergo the testing themselves, to get a clinical evaluation, to be counseled by a clinician, their own primary provider or the health department or Planned Parenthood. But when that's absolutely not feasible, expedited partner therapy could be used to facilitate treatment of these patients. It's not yet legal in all 50 states, amazingly enough. Minnesota just joined the ranks, I think it was in 2008 or 2010. Fairly new to the game. Here in Minnesota, I looked up the statutes. You don't have to read all these things. These are the statutes on prescription of legend drugs, which are just drugs that are approved by the FDA. And if you scroll way down, I found this statement that says basically that we're not prohibited from prescribing it. I looked in Wisconsin, and they actually, the law goes so far as to protect practitioners from liability against injury or death to a person who takes an antimicrobial drug that was given through EPT. So they're protected on that end. For here in Minnesota, they're just basically telling us if you really have to do it, we won't stop you. So take that for what it's worth. So those are the laws that affect us. Now, how about the laws that affect and protect our patients? Since the 70s, legislation has gone through that expands the rights of minors when it comes to their own health care. And they were enacted not to undermine parents' authority, but it was recognized that there are cases where notifying a parent would pose an obstacle to an adolescent seeking care. And in those situations, a teen's right to privacy supersedes the parent's rights to know. And from both a clinical and a public policy perspective, protection of confidentiality of adolescents has really been based on recognizing that some minors wouldn't seek care if they had to get their parents' permission, and that foregoing that care would have negative health implications for the patient and for the community at large. And again, I looked at the Minnesota statutes, and everyone's likely aware that minors have the right to give consent for health care when it's related to pregnancy, STIs, substance abuse, and mental health emergencies. What you might not know is this piece here, that you're protected by law and allowed to give information to a parent or legal guardian of any treatment given or needed where, in your professional opinion, failure to inform them could jeopardize the health of the patient. For me, that manifests itself in the ED when a patient has a positive pregnancy test. Whether I'm interpreting the law correctly or not, I feel like it's on my side in these instances, and I will tell a patient, you know, you're pregnant and that could really affect your health, and it's important that we tell your parent right now, and I can tell them for you can tell them yourself, or we can do it together.
Were you already out here?
So I feel like the law's on my side in that case. Another aspect of confidential teen care is that it's very tricky is the financial aspect.
He was down
If they
here?
come to the ED looking for STI testing and they're under their parents' insurance, the bill will still go to the parents and they'd still be able to see what was done. And so you kind of lose that altogether there. So if they absolutely don't want that to happen, then they are responsible for the cost of the test. It's a major flaw in the confidentiality process, but it is what it is right now. And just being forthcoming with patients, I mean, is the best we can do.
That makes Daddy very angry, Gregory.
You've likely heard of the term emancipated minor before. In Minnesota, this really isn't a thing that exists. There are no laws that give clear guidelines about how youth can become emancipated before they turn 18 or when a youth should be emancipated. There's no standard process that a youth can follow to be emancipated here in Minnesota. There are some minors that can obtain any kind of health care without parental consent, which is kind of like being emancipated. And those are minors who've been married, who have given birth, or who live separately from their parents or guardians and are financially responsible for themselves. So I've touched a bit on some of the aspects of adolescent STI care in the pediatric ED, but I would like to dive into it a little bit further. First of all, some people ask, is the pediatric ED an appropriate venue for screening for asymptomatic STIs? And I would argue a hearty yes. So studies suggest that adolescents often only seek medical attention for acute care issues and rely heavily on emergency services for their care needs. We know that male adolescents especially become disconnected from healthcare as they age. They're not plugged into gynecologists and things like girls are. And when they do seek care, they have a predominance of visits to the ED. Emergency departments, including urban pediatric EDs, see a patient population with a high STI prevalence, and so screening asymptomatic individuals in these venues might be an important component of STI reduction initiatives. The CDC has even started to recommend that screening efforts expand to include the ED setting. So this is fairly new. Does anyone know who this is? Of course, it's salt and pepper. Very good. As we've discussed, making a dent in the STI problem requires a series of events starting from having a conversation with your patient about it, to testing, to follow-up, to providing treatment to the patient and their partners. Let's kind of start at the beginning, see how we're all doing with sexual history taking. Dr. Goyle and a group at CHOP did a retrospective review and measured the frequencies of documentation of sexual history by clinicians during routine adolescent well visits. Aged 13 to 19, these are kids coming in for well child checks. It was a group of pediatric primary care practices affiliated with CHOP. So show of hands, who thinks more than 75% of these kids had a sexual history documented? Well child check. No takers. More than 50%. Okay, more than 25%. Less than 25%. All right, less than 25%, 21.2% had a documented sexual history. Factors they looked at that were associated with having one documented was older patient age, black race, public insurance, and then female clinician. So good job. The same crew at CHOP, they conducted a second of a different study, a different STI study of adolescents coming to a pediatric ED with chief complaints of lower abdominal pain and or genitourinary complaints. The study was on something else, but they abstracted the charts and looked for whether or not a sexual history was documented in the emergency department. And it was a good amount, but almost 20% didn't have a documented sexual history. And so these are patients that were coming in with lower abdominal pain, genitourinary chief complaints, and they were also enrolled in a study about STIs. It's like, I don't know what else they had to do, like wear a shirt that said, ask me about sex. It should have been 100%. So we can all improve on this step of the process. In the emergency department setting, surely patients with STI-related complaints should get a sexual history documented. Maybe that kid who comes in with a sprained ankle and has his whole hockey team there doesn't need that, and sometimes we don't have the time for that. If they're by themselves, I like to ask, because maybe he's not going to go to the doctor again in the next year. But we should surely be taking them in patients where the chief complaint fits. Another group that I think should probably be asked is the mental health patient population. In our emergency department, we see a significant number of mental health patients. We adjoin the Riverside ED, and they have the Behavioral Evaluation Center there. You might know it as the BEC. And so we do the medical clearance for these patients before they go over there for their behavior evaluation. And this patient population is at an increased risk for STI. They have high-risk sexual behaviors, impaired judgment. Most of them have high-risk peer groups. So all of these factors put them at an increased risk for STI. There was a comparison study of adolescent inpatient psychiatric patients versus just some school-based adolescents, and the inpatient psych patients were 2 times more likely to be sexually active, report unprotected sex, use IV drugs. So these patients are clearly at an increased risk. There's really very little literature about gonorrhea and chlamydia in this population, especially in the emergency department setting. There are some HIV studies, but really nothing that looks at other STIs. So I thought I would start really simple and just ask the question, do adolescent mental health patients that come to our ED have a sexual history taken when they come see us? Did a retrospective chart review and looked at 285 patients with mental health or substance use related chief complaints. And how do you think we did here with this patient population? Anybody think more than 50%? More than 25%? Less than 25%? It's actually not terrible. It wasn't great. So about a quarter of these patients had a sexual history documented. The only demographic that was significant was gender, with female patients being more likely to have a sexual history documented. I looked to see if it made a difference if there was a resident involved in their care or not. It didn't make a difference, and the effective patient race was not significant either. In the patients that did have a sexual history documented, well over half were noted to be sexually active and appropriate for STI screening. So I threw aside the ones that said they weren't sexually active or had just been tested, and that left a good chunk of patients. And however, only 38% of them were screened. So I feel like that was quite a few wasted opportunities that we can improve on. Again, these are patients who may or may not see a primary care physician. So now for the most important part of this talk, in my totally biased opinion, is the work that I began as a fellow at Cincinnati Children's Hospital, screening for asymptomatic gonorrhea and chlamydia in the pediatric emergency department. And doing research on this patient population and regarding this topic came with some interesting experiences and points that I would love to tell you all about. The aims of this study were first to determine the proportion of gonorrhea and chlamydia infections in asymptomatic adolescents. And then second, to determine reasons why they might refuse to have a urine done, to try to tease out some potential barriers to screening in this patient population. It was a prospective study, enrolled a convenient sample of teens. The age cutoff in Cincinnati's ED is 21. Here it's 18. So I enrolled 14 to 21 years of age who presented to the ED with non-genitourinary complaints. So we excluded teenage girls with abdominal pain, dysuria, vaginal bleeding, vaginal discharge, males with dysuria, penile discharge, or any STI concerns. And the study was carried out in the emergency department at Cincinnati Children's. They see approximately 90,000 visits each year. And as I hope I've shown you, physicians are not always the best at asking a sexual history, and additionally, patients aren't always truthful with their sexual history. So I hoped to reach patients that wouldn't otherwise be truthful and kind of cut that part out altogether. And so we didn't ask sexual history. That was not part of the inclusion criteria to be enrolled in the study. We knew that we'd be picking up some patients that maybe have never had sex before, but I was willing to take that gamble in order to get patients that really should be screened. The consent process was interesting. It involved approaching patients in their room and asking anyone present to step out. We just said this is a confidential topic. Would anyone else please step out so we can talk with the patient about the study? And so if they didn't want to leave or the patients didn't care if they stayed, it was not an exclusion criteria. If parents were present, we just pushed forward anyway. We asked the patient if they'd like to give a urine. I pretty much told them, the recommendations are that people who are sexually active be screened at least every year. I didn't ask them if they were sexually active, but I just said, would you like some free screening today? If they wanted to, great. If they didn't want to, fine. I asked either way if they'd like to fill out a survey for me. So they could do urine, they could do the survey, they could do both. We asked the IRB to waive the need for parental consent or for adolescent written consent or assent. It's been shown in some studies that the need for these decrease teen participation in STI research. And we wanted to take that off the table, and we were granted our request pretty easily, actually. I was impressed. So we would just document that we got verbal consent, but the patients did not have to sign anywhere. For those of you who have not already been inundated with pictures of my children, these two are mine, and they're free, and so it's been like all urine all the time at my house as we are potty training. So as I mentioned earlier, we know the importance of good confidential contact info. So for the urine screening portion of the study, I made sure to get a good number from the patient and told them that I would be contacting them personally with the results only if they were positive. All the testing was provided by the Ohio Department of Health. They provided this free of charge to us. They actually had a grant from the CDC, and we're doing a project called the Infertility Prevention Project. So I was very lucky that that coincided with my study nicely in the time frame. They would fax all the results back to me, and then I would contact the patients if they were positive and call in a prescription for them to the pharmacy of their choice. If they were positive for gonorrhea, I would counsel them on where they could go to get treated. Most often I would tell them it was easiest just to come back to the emergency department, but they could go to Planned Parenthood. The health department was right down the street, so I gave them their options but told them the importance of it. And then also counseled them on safe sex practices and making sure that their partners were all treated. And then a week later, I contacted the pharmacy for patients with chlamydia to see if they picked up their prescriptions, and then checked the electronic medical record to see if the gonorrhea patients had come back to our facility. The questionnaire was administered electronically in the patient's room using a laptop, and we used Qualtrics online survey software. I initially pilot tested it on some adolescents in the emergency department to assess for clarity and ease of reading. And it got me really excited about the project because many of the patients who pilot tested the survey asked me if they could have the testing done that day. So here's just a glance at what the sexual history question looked like. This was the part where we did ask about sexual history. It was totally anonymous and not linked to the patient at all. If the patient hovered over those words in blue, it would give them definitions of things. It was a bit of a choose your own adventure. Patients who indicated that they were not sexually active at all would get fewer questions and slightly different questions. But all the survey questions were basically aimed at determining reasons why a patient would not want screening done or refuse screening in this setting. Things like parental presence, privacy concerns, concern for a negative reaction to a positive test, time, inconvenience, those sort of things. Overall, I had 719 patients agree to participate in the study. 133 participated in just the urine only, 307 in the urine and survey, and then 280 completed just the survey. So a total of 440 patients agreed to give me urine. Of those, 403 were actually able to provide urine, and urine that was processed and resulted correctly. I was interested in comparing the patients who agreed to the urine screening versus those who didn't want to give urine but still participated in the study. And the variables included age, race, gender, form of insurance, and whether or not they had a primary care physician. And the mean age was just over 16 for both groups, and those who agreed to urine testing were more likely to be Black and have public insurance. Overall, about 10% of the patients who were screened were positive for at least one STI, which seems like a lot, doesn't it? 10 patients were positive for gonorrhea, and 35 were positive for chlamydia, and there were 5 patients who were positive for both, so that's why the number adds up to 45 down below. In comparing the demographics of those who were positive versus those who were negative for any STI, race was the only significant variable, with 87.5% of those testing positive were Black. It was interesting to me that age was not significant. In fact, nearly a quarter of the positive patients were in the youngest age group, the 14 to 15 range. I had the distinct pleasure of contacting all of these positive patients myself with their results. I bought a burner phone from Walmart, and so I'd have the ability to call and text them. And then they could call me back anytime, day or night. It was fabulous. So I'll get to the actual numbers in a second, but because that's what gets published. But to me, some of the most interesting information were the conversations that I had. Many patients, interestingly, did require a text message to get back to me, so I found that kind of held true. Many of the patients were angry, some were sad, some were surprised. I had a mom who answered the phone who had been present when I presented the study. So as soon as she heard who was calling, she knew what was going on. She gave the phone to her son, who we talked, and I asked him if he had any questions at the end. He said, no, but my mom does. And she had some good questions, but then at the end she just wanted to tell me that she has a bowl of condoms on the counter and he is welcome to take them whenever he wants. So she was very upset that this happened. I had another patient who, bless her heart, called me so many times with so many questions, and including calling me with her boyfriend on the phone. Can he get, can you write him a prescription also? And I would have loved to, but at the time, Ohio's expedited partner therapy law, it did not allow it in Ohio at the time. But it was interesting to me the good questions that these patients had, and a lot of them had questions after the fact. So I would talk with them, I would get a text or a phone call again in another day or two with more questions. And so they really just need our help with this. They might not be thinking of the questions at the time that they see us, so being available for questions after the fact, I think was really helpful to a lot of them. And after contacting them with their results, then I called the pharmacy to see if they followed up or checked in the EMR to see if they got treated for their gonorrhea. And among the gonorrhea patients, 7 of the 10 followed back up in our emergency department for their treatment. 3 didn't come back to our institution, but that doesn't mean they didn't go elsewhere. Among the 30 chlamydia-only positive patients, I was able to confirm that 18 filled their prescriptions. 5 patients were actually treated elsewhere. 1 patient told me they were going back to their PMD for retesting because they didn't believe me. And then 1 I got a hold of had actually been motivated by the survey to go and see his campus physician after getting tested with me. And so in between me getting the results back and contacting him, he had gone and already gotten treated at his campus physician and tested for everything else. So I thought that was kind of neat. And then 3 came back to the emergency department to get treated. Either they didn't understand or they were really worried about other things, and so they came back. And then there were 2 that I just wasn't able to contact at all with their results. So the number documented to have received treatment was 75%, but I like to think that everybody that I contact eventually got themselves treated, and so that potentially is 95% of the patients were treated, which I think is pretty good numbers. For my questionnaire, I had 587 patients complete the survey, and about half of them had agreed to testing and half had not. The patients who declined testing had a lower perceived risk of being positive for an STI, but it was interesting of these patients, 80% said it wasn't at all possible that they could have a STI, but the majority of them indicated that they were sexually active. So I'm not sure what the disconnect was there. They just don't think that it could happen to them. So it's an interesting patient population that could use a little bit more energy. Patients who agreed to testing were more likely to report that they were sexually active or have inconsistent condom use. So it was kind of an indication that these patients did self-select a little bit, like I'm at higher risk, so I should agree to the urine testing. And interestingly enough, I put so much effort into confidentiality, but it didn't matter at all if there was anyone else in the room to the patients, whether they agreed to do it or not. There were lots of limitations to the study. First, it was a convenient sample of patients enrolled when I was able to be there, or a research assistant. Additionally, the testing was free and was not at all documented in their chart. So it was absolutely no harm to them to do it. And so it might be different if there was cost involved or if it was going to be in their chart. And also there's maybe some self-selection bias, patients agreeing to give urine samples if they already thought they might be at risk and need testing at baseline. So I hope that I've convinced you that STI reduction efforts are worth your time and efforts. So what are some of the next steps? So just kind of review everything. The literature suggests we can all improve our efforts to take sexual histories from our adolescent patients. Screening is easy to do with nucleic acid amplification tests, and they can be done on urine, self-swabs. You don't even have to be involved. Obtaining a confidential phone number at which to reach patients with positive results is imperative, and then getting the patients, as well as their partners, the treatment that they need, as well as counseling them on abstaining for a week and using safe sex practices going forward. Without any one of those steps, we can't have successful STI reduction initiatives. So how can the Pediatric Emergency Department contribute to all these efforts? We've seen that there's a high percentage of asymptomatic gonorrhea and chlamydia in this teen population. So should we just be screening all comers? There's issues with that also. We have to keep a certain flow going in the ED. We don't have time to screen everybody for everything. So this is being looked at by my mentor, Jen Reed at Cincinnati Children's Hospital, and by Dr. Monica Goyle at CHOP, and hopefully they'll all be providing us with some guidelines in the guidance in the upcoming years. Here at Masonic, I'm starting by focusing on our highest risk population, the mental health patients. Now that we've seen that we can improve on our first steps in this process by getting a sexual history and having the conversation with these patients, hopefully we can move forward in improving our screening efforts and developing plans for follow-up treatment and coordination of their care. The Get Yourself Tested campaign is probably one of the best campaigns out there right now for reaching out to adolescents. The partners for this includes the CDC, Planned Parenthood, MTV. There's a lot of people on board with this movement. You can order posters, free buttons, and stickers and things online. And I'll put a plug out for April is STI Awareness Month, so get super excited about that. You can go to itsyoursexlife.com to get more information about that if you'd like, or direct patients to that website. I have a few important thank yous to give before I take any questions. First is my mentor, personally and professionally, Dr. Jennifer Reed, Associate Professor in the Division of Emergency Medicine at Cincinnati Children's Hospital, just super instrumental in my fellowship. Zainab Alfath is a student from the University of Minnesota. She worked really hard on the mental health patient chart review. I'm really appreciative of all her efforts. And then Dan Nierheim is our research coordinator. Many of you may know him. He helped me every step of the way on my mental health project. Some of you may have experienced that getting data out of EPIC isn't always the easiest, especially if your patients are being transferred elsewhere for behavioral care. So he was my champion getting all that data for me. And a big thank you to my squad, especially to Mark and Ron and Jeff, who've been so supportive of me in my research interests. And I hope that everyone here works with a group that is as supportive and as amazing as my crew is. And the biggest thank you has to go to my awesome husband and my babies for putting up with a little less mommy time these last couple of weeks while I prepared for this. Now, does anyone have any comments, questions, concerns, personal STI stories they want to share? Do we need a mic?
Thank you for a very interesting talk. What is being done at the school level? Are kids able to get screened at school?
There's not a standard process for screening in schools. There are certainly some schools that have clinics. One thing that's important to note about schools is one of the laws is, I don't know if you've heard of FERPA, but it's just basically that gives parents the permission to look in children's charts and know anything that happens at the school about patients. So the clinics that are in place and being set up really have to be careful to be outside of those laws for confidentiality purposes. But there are certainly schools that are working on it and looking into it, but there's nothing standard or there's no nationwide sort of push. Dr. Roback.
Thank you, Kari. That was really terrific. When we are taking care of adolescent females with almost any complaint, we do urine pregnancy tests without asking anyone. We just do it. And what do you think the approach should be for broadening our screening for adolescents for STIs?
So often we will send, like you said.
And who's going to pay for it?
Right, yes. So Dr. Roback's question is, we often just send a pregnancy test. We don't mention it to anybody. We just do it. And that's great, but what should we be doing about STI screening? Should we also just be sending that off, and who's going to pay for it? The pay for it part of the question is their insurance is going to pay for it, and if they don't want their parents to know about this, then they will pay for it themselves. I don't think we should just send it without talking to them about it, because if that result comes back, first of all, we need a confidential phone number, and so asking them for their phone number without telling them why is probably sketchy, especially if it's one of you guys. So having that conversation with them about if these test results come back positive, I need to get a hold of you. And I think it also gives you the opportunity to get a sense of what their risk is and give a little counseling as well.
That was a great talk, Kari. To address Mark's point, I think we save society money by doing testing because identifying these patients is a good investment. We used to say it would protect their fertility, particularly for young women, and that's, I think, a whole separate discussion. At what point should we go back to doing bimanual exams in some of these girls and young women, I should say, and which one should be admitted for PID treatment? But I want to ask you a different question. We seem nationally to be losing this battle. The CDC says STIs are at an all-time high, in spite of all the smartphones and apps and internets and texting and so forth and so on. And I'm just curious of what your thoughts are in terms of what's driving that. Why are we having such a crisis with STIs? And does PrEP play a role in the MSM population?
So, great question. There's a lot there. I think there are a variety of reasons why teens are at an all-time high for their STIs. One is, I think, social media, the mainstream media, everything has gotten out of control with sexuality in this country. Kids are having a lot of sex, and there's really no social stigma attached to it at this point. I think another piece of the puzzle is that, as I showed, a quarter of patients are maybe at best getting sexual histories taken from their physicians, and a lot of them aren't seeking care for a variety of reasons. So any opportunity that we have, whether that's in the ED or in the primary care offices, to get a hold of these patients and talk to them about it, even if it's just having a conversation, planting a seed. So it's okay to not have sex. There's a lot of other things that are more important in your life, and if you are having sex, then we need to be treated, and not being afraid that we're going to offend parents, especially here in Minnesota where everything is so kind and nothing bad ever happens. Having conversations with patients and their parents about, okay, this is happening, this is a problem, and we need to kind of start where we can. I hope that kind of got to it a little bit.
That's really excellent. Thank you.
Thanks.
There's another subgroup that I think will be totally ignored unless we ask the question about, and that is young adults who are intellectually disabled. Has anybody ever looked at that? And do we know anything about risks for STDs? I mean, I would think they are particularly vulnerable and unlikely to be queried population. That
is a great question. And I did not come across any literature about that patient population. There are so many small subgroups. It's like, where do we start? For me, that was with the mental health population, because I think that kind of fits into that a little bit, some impaired capacity and a higher risk. But I think that's also an excellent point that group really should be looked into as well.
And I don't have the literature on that answer, but it brings the next question, is that people think confidential health care for adolescents with STIs and pregnancy means don't ask. And so the sexual history is really important, because these vulnerable adolescents may actually have a, quote, boyfriend, somebody they refer to as a boyfriend, that is actually an adult, and somebody that they are not allowed to, by law, have a sexual relationship with. So confidentiality does not allow them to have that relationship, and then mandatory reporting kicks in. So I want people to remember that confidentiality does not extend to an illegal relationship. So taking a sexual history is important, so that you know whether or not you have potentially a trafficked adolescent or a vulnerable adolescent where there might be a report needed for sexual abuse, sexual assault. So the sexual history is so important, and I'm glad that you've pointed out that.
And I don't know if speakers are allowed to ask questions, but Nancy, can I ask you a question as long as we've got you here? In patients that are sexually active, I rarely, if ever, ask about the age of their partner. Is that something that we should be asking? And if we get the information that we don't like, what should we do with that information?
You should be asking about it. And we were going to put together a flow chart after we recently had this evening rounds where we had one of the prosecutors come over from Hennepin and talk about where does the limitations of adolescent confidentiality end. And she went over some of the age and some of the rules on that. And so she gave us some good guidance. We were going to put together a flow chart for people. So it's just simply asking an adolescent, hey, tell me about your partner. Have that casual conversation, build rapport. They may not know where you're going with that. But it's important to know, is that somebody who is an adult? Is it somebody that they're not supposed to be having a relationship with, so we know where our reporting requirements are?
And then we just contact social work if it's a 14-year-old with a 20-year-old boyfriend.
Yeah, that would be inappropriate, or with, an adult who's living in their basement, or some other relationship that has to be reported. Or maybe it's an adolescent who's coming to the ED who's seeking testing for infection because they're being trafficked, because they're living in a motel, because of something else. So, yeah, we'll be putting together a chart for you.
Awesome. I love this, you guys. I love talking about this.
That was a great talk. Thank you very much. I do think that routine testing would be helpful for destigmatizing testing. And to Mark's question, PrEP has recently been found to change T cell function and increase risk for the development of syphilis, as opposed to changing people's sexual behavior. So there is, PrEP is pre-exposure prophylaxis with Truvada, which is very effective in prevention of HIV infection in high-risk populations who choose to have unprotected intercourse. And so there is some data indicating that it changes T cell function and increases your risk for syphilis, and may help to explain the increase in syphilis in the gay population that's been in the recent decade, as PrEP has been used more for prevention of HIV in the gay population. And so there is recent data that it is changing T cell function as opposed to changing people's behavior in terms of high-risk sexual behavior. So but in terms of Mark's question, I think that if we do more routine testing, it may change people's relationship with testing. And we know that the more you test, the more you destigmatize testing, the more you get people treated, the more you treat, the less infection you have.
And I think in some of our patients are here for very specialized reasons and see our subspecialists, and maybe don't follow up with their PMDs as often because of that, and so maybe expanding to doing screening in some of our specialty clinics as well.
Yeah, I think the wonderful thing that you had in your research study was that the testing didn't cost anything, as far as I understand, and yeah. I think the fact that it will cost the teenager or their parent money that will be itemized on their insurance statement is at least a perceived very real problem to me. And certainly at our clinic, we have spent hours going round and round about, do we test every teenager who comes through the door and then destigmatize? We just test everyone. This is what we do. We want to keep our teenagers safe. Or do we try to do targeted screening with teen screens and just test the ones who are sexually active? And so I would love for us to think about even getting a small grant and partner with our clinic in the ED and see if we can find a way to test teens and not have them get charged for it, because I think a lot of it is provider reticence to do it if we're worried about the impact on the teen. I think that is a part of why it doesn't happen, or the teens refusing because they're worried about it. And if we think about the cost of testing versus the cost of what we're preventing, it would be a good investment, and it could be good proof of concept. So maybe we can talk more about that.
Yeah, that's a great point. And I there's not much literature about it, and I don't know if it would be an interesting thing to look into. Is what if in primary care practice, every time you had a teen well visit, you just talked to the parents to say, I want to establish this relationship with you and your teen. And part of that is, maybe they need testing for this, maybe they don't, but this is something that we'd like to do. And I don't, maybe you need to have conversations with me to help you have conversations at home. I mean, that we're getting out of my area when we start talking about the primary care office, but I think there's just so many areas that we can work on to improve this.
Adding on to Emily's point, do you know if there's data about the prevalence of STDs in people who say they're not sexually active and have never been sexually active? I know we always test them for pregnancy, but...
Yep, there are plenty of tests where they asked, or plenty of studies where they asked that question in certain settings and then looked to see who ended up being positive anyway, and it's a significant number.
So we really can't go by who says they're sexually active.
For the most part, but there's certainly that number of patients that you're still going to miss if they're saying that they're not, but they are. Along with the virginal pregnancies, yes, that's right.
Great talk, thank you very much. I was wondering, like in the setting of the emergency room, the lots of cares, how do you handle the time to deal with the primary program and with the screening? Do we have some sort of way merge the screening into part of the routine questioning so that kind of really catch up whatever we possibly missed whenever that chaos settings?
Yep, that's a great question. I think the question you're asking is, like, how do we roll this into the flow of the ED in our usual care, which can be tricky, especially when we're talking about urine samples. And in fact, you may have noticed that 440 kids offered me or agreed to do urine, but I only got 400, and that was a significant portion of those were kids that just couldn't pee by the time it was time to leave. So getting a urine sample. Often in the ED, we're wanting a clean catch because we're wanting to make sure you don't have a UTI, but then we can't use that urine. And so talking about self-swabbing. So it does become a flow issue if we're waiting for them to do a clean urine and then a dirty urine. And so moving more towards using self-swabs. We can't do that for the men. That not many of them will be like, okay, I'll stick this in my penis. So we do need a urine from them. So it is difficult to work that into the flow, and I think it would have to be more of, if we're going to do this across the board, and that's what they're looking at in Cincinnati and CHOP, it would have to be like, as soon as you're registered, you're given a cup and told to pee to kind of facilitate that sort of flow. The discussions about the testing, it can happen pretty briefly, and in my mental health patients, I feel like it's particularly easy for us to do this because the BEC usually wants a urine sample for our UTOX, and so that's a dirty urine sample right there. So we're getting those on the patients anyway, so that kind of fits really easily into our screening. And also these patients tend to come by ambulance without a parent initially, and so it's a great time to quick get a history from them and talk to them about the screening and grab a confidential phone number. But that's one of the things that's going to be the biggest, I think, barrier is the flow of the ED. Any screening things that we're doing in the ED, primary care things in the ED, really kind of take from that time of the pace. And so teasing that out and getting it really streamlined and perfect will be a big factor in making it successful.
Thank you very much.
Hey, Kari, great job. Thanks. So I noticed in your study that there was a high incidence of positives in the 14 to 15-year-old age range, but then your study is 14 to 21, correct?
Mm-hmm.
What about going lower?
It was a push to get 14. I had a lot of pushback from my colleagues at Cincinnati, like, that's too low. I mean, 15, maybe 16. I was like, we need to, it should be lower. I agree. And there's definitely patients where I walked into the room and I'm like, oh, you look like a baby, but I'm going to present this to you anyway. There's one girl who seriously looked like she was 10, and I offered her the study, and she said, oh, no, thanks. I was just positive for gonorrhea last week and got treated. And I was like, oh. So I fully agree. I mean, we probably should be going at least a year lower, if not more.
And then also, gonorrhea, chlamydia, my understanding was that the urine was not as good in females as it was in males, but I think Nancy has changed my understanding of that. Can either of you answer that?
Males, females, it has really good, I mean, we're talking upper 90s sensitivity and specificity in the urine, and probably a little bit better if you have them self-swab, because you can get right to the source of things. And it's easy. I mean, most of these girls have used tampons before, and it's really no different. I just tell them it's like putting in a tampon, spin it around a couple times, and you're done. Yes.
Hi. So in several of the studies, black race fell out as a difference. And in your study, I think it was associated with an increased risk of infection, but also increased willingness to consent to the study. So my question is it your sense that there's an increased awareness of the problem in that population? And if so, what's leading to that? And are the educational efforts in that community better than what we're doing in other communities?
It actually, in pretty much every study of STIs in teenagers, that holds true. That Black adolescents are more likely to be positive, more likely to be tested, more likely to be asked the question, more likely to consent to this stuff. And nobody has really said exactly why that is. There's been some hypotheses that it's just more prevalent in that community, so they talk about it more, it's more well known, and maybe there's less of a stigma of getting tested or being positive. There's nothing concrete, but it holds true across the board that is always the case in pretty much every study. But it definitely a targeted audience that seems willing to hear about it and consent to these studies, and an audience that we could hopefully get a hold of. Okay, it's time. Thanks, everybody. Appreciate it.